The second diabetic emergency I'd like to cover is hypoglycemia. This is obviously much more frequent than diabetic ketoacidosis or HHS, and it varies from mild to severe, where mild is usually treated by the patient themselves. Before I go on to pathophysiology and the treatment of such condition, I'd like to go over what happens normally in patients as glucose level goes down. So as our glucose level goes down, the insulin secretion by the beta cells decreases. So once the blood sugar reaches 84 milligram per deciliter, we notice a decrease in insulin secretion by the beta cells. When it reaches 72 milligram per deciliter, this reduces brain glucose uptake and also insulin secretion, and counter-regulatory hormones, that's glucagon, epinephrine, are released in response to this level of glucose. Once the glucose level goes down to 60 milligram per deciliter, adrenergic symptoms, which I will go over, appear. And person starts eating because the person realizes that the blood sugar is low. However, with glucose level of 55 milligram per deciliter, neuroglycopenic symptoms appear. And with glucose level less than 40 milligram per deciliter, somnolence and behavioral changes are prominent at this stage. With a prolonged plasma glucose less than 30 milligram per deciliter, coma, irreversible neurological damage, and death ensues. And severe hypoglycemia, as we all know, does predispose to arrhythmias, MIs, and stroke, especially in the elderly. The response to hypoglycemia in diabetes is different from normal people, in that the first defense mechanism to hypoglycemia in normal people is usually decrease in insulin secretion. However, in diabetics who are on, let's say, sulfonylurea or insulin release continues despite decreasing glucose levels. Glucagon, which is important in the recovery from hypoglycemia, normally is present at the diagnosis of diabetes, but later that response declines with duration of diabetes. Similarly, epinephrine, which is important to give you these adrenergic symptoms, is attenuated, and some patients may develop what we call hypoglycemia unawareness. Here are the adrenergic and neuroglycopenic symptoms. It is important, of course, for us to have adrenergic symptoms first. This is what I call the bell that tells us something is wrong. These are diaphoresis, hunger, tingling, tremulousness, anxiety, and palpitation. When we feel those symptoms, we realize that our sugar is low and we go and eat. However, if we don't do that, or if we cannot feel that, and blood sugar continues to go down, then we develop neuroglycopenic symptoms, and these are visual changes, confusion, unusual behavior, weakness, warmth, lethargy, and later on develop seizure and coma. These are more serious symptoms and portend a poor response. A condition of hypoglycemia unawareness has been recognized in diabetics who have recurrent hypoglycemia. This is called hypoglycemia-associated autonomic failure, in which the autonomic symptoms suffer as a result of hypoglycemia. So recurrent hypoglycemia has been shown to reduce the glucose level threshold that precipitates the counter-regulatory response that tells us to go and ingest glucose. As a result, patients do not experience the symptoms from the adrenergic response. And the first sign of hypoglycemia in those situations is a neuroglycopenia, that is confusion. HAF is a form of functional sympathoadrenal failure, which is different from autonomic failure as a result of chronic complication of diabetes. This HAF is associated with a 25-fold or greater risk of severe hypoglycemia during intensive insulin therapy. The definition of hypoglycemia in diabetic is slightly different from non-diabetic. And here we define hypoglycemia as all episode of an abnormally low plasma glucose concentration, with or without symptoms, that expose the individual to harm. And the reason we use this is because some people have symptoms at a higher or lower level than this. The level of finger stick glucose of less than 70 milligram per deciliter has been used in this situation for two reasons. One, this forms the lower limit of physiological fasting non-diabetic range. And two, the normal glycemic threshold for glucose counter-regulatory hormone secretion occurs when the blood glucose level goes below 70 milligram per deciliter. Patients who develop hypoglycemia develop it because they have risk factor for hypoglycemia and they are risk factor for HAF. These include absolute endogenous insulin deficiency, a past history of severe hypoglycemia, hypoglycemia unawareness, or recent antecedent hypoglycemia, prior exercise or sleep. Intensive insulin therapy or intensive glycemic therapy is associated with an increased hypoglycemic events and situations that increase the risk of hypoglycemia, that such as insulin excess, decreased oral intake or exercise, increased sensitivity to insulin such as occur in hypothyroidism or hypoadrenalism, and reduced endogenous glucose production such as following alcohol ingestion, or reduced insulin clearance such as in renal failure. These all are recognized as risk factor for HAF. How do we classify hypoglycemia in diabetic patients? Well, we classify as severe hypoglycemia usually those episodes that need the help of other people other than the patient. Documented symptomatic hypoglycemia, that is a patient who has hypoglycemia who measures blood sugar and is low, or asymptomatic hypoglycemia, that is a measured glucose that is low, but the patient is asymptomatic, and probable symptomatic hypoglycemia in that the patient feels symptoms, but it doesn't correlate with glucose levels. And there is pseudo-hypoglycemia, which is very common in diabetics. These are symptoms that are not classical of hypoglycemia that occurs for other reasons. Dizziness, for example, from other causes, and anxiety from other causes, and so on. The risk factor for severe hypoglycemia are more or less the same risk factor for HAF, and they are illustrated in this slide, and they more or less correlate with the others. I will just say that the most common reason for hypoglycemia is exaggerated mismatch between insulin and nutrient absorption. Most patients do not match their insulin dose to the amount of carbohydrates they are eating. Most diabetic patients who are in insulin secretagogues such as sulfonylurea or in insulin therapy will develop hypoglycemia. The frequency is much more in type 1 than type 2 diabetes patients. As you can see here, the average record is about 2 per week for type 1, although it varies from person to another, and it varies according to their degree of glycemic control. So a patient who's near normal blood sugar, such as pregnant, who's on insulin, will probably develop 2 per day sometimes. Type 2 diabetes have less hypoglycemic episodes than type 1. However, apparently, patients with sulfonylurea have the same incidence of hypoglycemia to that who are in insulin analogs that are long-acting, at least at the beginning of therapy. It is well known now that there are more ER visits, emergency room visits, due to hypoglycemia than due to hyperglycemia. In fact, last year, the numbers exceeded those with hyperglycemia. So which are the agents that predispose those diabetic patients to hypoglycemia? In general, these are sulfonylurea, meglitinides, and insulin therapy. Insulin therapy, short-acting, much more than long-acting, regular, more than the analog, and intermediate insulin, NPH, more than the 24-hour peakless insulin, such as glargine and detamine. However, medications that are not insulin secretagogues do not produce hypoglycemia. These are metformin, which are well known to be the first agent of choice, alpha-glucosidase inhibitors, thiazidinediones, and the recently introduced group of incretin, such as GLP-1 analogs and DPP-4 inhibitors and SGLT2 inhibitors. This slide reveals the frequency of hypoglycemia as a result of intensive therapy in those patients in those three studies that are being done to address the effectiveness of intensive insulin therapy in reducing microvascular complication. And as you can see, both in ACCORD, VADT, and ADVANCE, the incidence of hypoglycemia increases by about threefold as a result of intensive insulin therapy. In the study of ACCORD, the risk factor for hypoglycemia has been recognized to be the female sex, less education, greater age, longer duration of diabetes, 16 plus, which basically implies loss probably of glucagon secretion as a result of hypoglycemia. Patients of insulin, higher baseline A1C, so those patients who are being brought from very high A1C to normal will have an increased frequency of hypoglycemia. And individuals whose hypoglycemia, whose A1C did not drop rapidly in the first 4 months of therapy, and those patients with renal dysfunction. So what are the consequences of hypoglycemia in diabetics? Well, this is not very well studied because it's very difficult to measure hypoglycemia in diabetics. Unlike hyperglycemia, where we measure glycated hemoglobin A1C, and we can tell how bad the glucose control is, in hypoglycemia, a lot of episodes go unrecognized. In type 1, it is more characterized than in type 2. So it has been attributed that 4 to 10% of death are due probably to hypoglycemia. And there's probably an increased risk of neuropsychological dysfunction and structural changes in the brain of children, but not adults. There is an uncertain effect on cognitive impairment in adults. In type 2, however, the data are sparse when it comes to mortality. However, one study shows that an increased risk of dementia due to severe hypoglycemia requiring hospitalization, but not due to mild hypoglycemia. And as we know, in experimental condition and non-experimental condition, hypoglycemia leads to arrhythmias, and in the elderly especially leads to falls with consequent fractures and morbidity. Hypoglycemia in the elderly is a problem in that symptoms of neuroglycopenia are more prevalent than adrenergic symptoms. So patients do not have that warning signs of adrenergic symptoms that allow them to go and eat. And this is because of age-related changes in the body. Some of it we know already, such as decrease in renal and hepatic function, but some are due to age-related decrease in beta-adrenergic receptor function. And there is also impairment in counter-regulatory hormone responses, especially with respect to glucagon and growth hormone. And as such, those patients at higher risk of falls, incontinence, frailty, cognitive impairment, and depressive symptoms. So if at all possible, we try to avoid hypoglycemia in elderly and choose agents with very low risk of hypoglycemia. In addition, we also try to change our target of glycemic control for patients at risk of hypoglycemia. How do we treat hypoglycemia? Well, in general, it is very simple. You give glucose, of course. So if a patient is asymptomatic, We generally recommend that they repeat the test because one could be mistake, an error. They should avoid driving, so they at that stage, and there is a choice of ingesting carbohydrate if they are afraid that they will be symptomatic. For patients who are symptomatic, we recommend that they ingest fast-acting carbohydrates such as sugar and water or juices. Generally, we recommend 15 grams. 15 grams is equivalent to half a cup of apple juice, for example. However, in severe hypoglycemia, where the patient is comatose or confused, you need a second person to help with treatment. And those patients in general should have glucagon injections at home, and it is the relatives or friends who should know how to administer glucagon. In the emergency room, of course, we have the intravenous glucose, and in general, we give 25 grams of 50% dextrose. In type 2 diabetics who are on sulfonylurea, it is important to continue to monitor those patients for probably 48 hours, since recurrent hypoglycemia in those population is common, and especially if the reason for hypoglycemia is unknown. It is important to prevent hypoglycemia, and the patient should be knowledgeable about the reasons for hypoglycemia. So education and empowerment is very important, especially for patients who are on insulin. It is important that patients take regular meals at regular intervals with regular amount of food. If for whatever reason the patient has not finished their meal, they should take some fast-acting carbohydrate to compensate for the decrease in their meal intake. They should frequently monitor their blood sugar, specifically for those who have hypoglycemia and awareness. And they need to be educated in how to use insulin, how to adjust it according to the amount of meal and according to the ambient blood sugar at that time. And we should modify glycemic targets. So somebody who is elderly, who is at risk of hypoglycemia, and who have comorbidities such as cardiac disease, our glycemic target should be different from those for young. So a glycemic target of hemoglobin A1C of 8 will be acceptable for those patients. And behavioral approach has been shown to work for patients whose symptoms are very subtle, such as a little bit of warmth or a little bit of dizziness. They need to respond to those rather than wait for the classical symptoms of adrenergic symptoms. And of course, at that stage, they should take defensive action in the form of ingestion of fast-acting carbohydrate. With that, I will conclude, and this slide shows the references where you can read more about the subject and enrich your knowledge. Thank you very much.